Hello and welcome. This video is a bit different. It is not about a clinical diagnosis or an approach to a symptom. In this video, I want to talk about how Emerg docs think. This is designed specifically for learners who are new to emergency medicine. Let's begin. Understanding how an Emerg doc think will help you decide what information to gather from the patient and how to present it. In this video, we'll focus on the questions to ask. In the next one, we'll sort out how to present the information you've gathered. As a learner, you might have seen something like this to gather your history from. Here is your chief complaint and history of presenting illness, a section for review of system, past medical history and past surgical history, family history and social history. And then we input physical examination findings, lab results. From then on, we put all that information together and we try to come up with a diagnosis and plan. Things are, however, a bit different in the emergency department. First of all, patients do not come in with a clinical diagnosis. Instead of saying they have diabetes, they might come in and say, "I'm feeling weak." Patients is now presenting with a symptom rather than a clinical diagnosis. Things tend to be busy in the emergency department. Instead of seeing a single patient, we may have to attend to a lot of patients at the same time. We also have a limited amount of time to gather the information we need to make a reasonable judgment on a diagnosis. To use our time efficiently, sometimes we may have to direct the patient to give a history. Since the patient is not trained to give a history, we are trained to direct them. In the emergency department, our main focus as practitioners is to be able to pick up the sick patient in a sea of other patients before something happens to them. And therefore, the cardinal rule in the emergency department when you're seeing your next patient is that we assume everyone is either going to die or lose a limb. Therefore, when you're seeing your next patient, we want you to think of diagnoses that can kill in either a few minutes, a few hours, or a few days. We want you to think about those diagnoses no matter what the presenting complaint is. If you break it down into a table, based on the patient's complaint, we can generate probably two lists, a likely diagnosis list and a deadly diagnosis list. Based on the combination of these lists, we then decide on what testing and treatment is required. Your main focus is to make sure this deadly diagnosis box is being filled. Remember, the deadly diagnoses do not need to be likely, but we need to think about all the deadly ones. Your mission for each patient you see is that you need to fill that deadly box. Let's say you're seeing a patient who is short of breath. What deadly diagnosis can kill her in the next few minutes, hours, or days? Can you think of a list? You may want to pause here and come up with your own list before we go further. Your deadly list might include something like this. How many did you get? After you've created this list, you will want to provide evidence whether the patient does or does not have each of these clinical diagnoses on the deadly list. In essence, you want to argue that the patient does not have any of these deadly diagnoses by providing evidence for it. Therefore, after you obtain the history of presenting illness from the patient, if they have not touched on these deadly diagnoses, you need to generate questions that ask for that specifically. Your questions will then be based on each of the diagnoses on this deadly box. For example, in this deadly box, we see things like PE, pneumonia, CHF, pneumothorax, and asthma. If the patient has not touched on those questions during the history of presenting illness, we need to ask questions about them. What are the questions that you want to ask somebody if you're worried about a pulmonary embolism or a PE? Well, you may choose to ask about risk factors such as immobilization, use of oral contraceptive pills, or previous history of pulmonary embolism. What about for pneumonia? What are the pertinent questions? Questions can include fever, chills, cough, sick contacts, sputum, and so on. What about questions for a pneumothorax? What kind of questions would you like to ask? A previous history would be helpful. Or perhaps there's a history of trauma that the patient forgot to mention. What about CHF? It's unlikely a 26-year-old will have CHF. However, we may want to ask things about congenital heart disease that the patient may or may not have told you at this point. What about questions for asthma? What are pertinent questions? As always, a history of it is helpful. What triggers the asthma and their previous history of asthma and how sick they usually get would be also very helpful for us. What if there's a secondary complaint? Sometimes the complaints are linked, such as maybe the patient who is short of breath is also complaining of a swollen leg. That makes us much more worried about a venous thromboembolism event. Sometimes the complaint is not obviously linked with each other. In that case, such as if the patient is complaining of, say, left eye pain, we may need to list another deadly list for this second complaint. Remember, your job when you see the patient is both to figure out what the likely diagnosis is, but more importantly, to figure out what the deadly diagnosis it is not. This sometimes can be very tricky and not particularly easy. In essence, we're asking you to work backwards from a clinical symptom to arrive at a diagnosis. And sometimes the deadly diagnoses are so far-fetched that they're not even going to be remotely likely. We still want to think about them to make sure that the patient does not have them. Remember the cardinal rule. We assume everyone is going to either die or lose a limb. We want to argue that the patient do not have any of the deadly diagnoses. On the blog, we will include other resources to help you get used to this way of thinking. And in video number 2, we'll discuss how to present all the information you have now gathered. Thank you for watching.